So I'm going to get started then. And what I'm going to do is say that I'm Robert Dempsey, and I have the honor of being the chair of the Foundation for International Education in Neurological Surgery. I'd like to welcome you all to this January presentation of our virtual visiting professor program. This has been and will be an ongoing program of education aimed at trainees, young neurosurgeons, early faculty, and old ones like me who are involved in global neurosurgery worldwide. Format will be an introduction by one of our junior or young neurosurgeons, often a graduate of our training programs, and then a short lecture by an eminent leader in the field, followed by dialogue and questions. That's where our young neurosurgeon will come in handy to sort of draw out questions or to read them if they have been submitted elsewhere. We will continue this to the end of the hour, and then there will be in our recording answers to any that we're not able to cover. So this is a wonderful opportunity. I'm particularly honored that my dear friend, Mubashir Qureshi, who is one of the real leaders in global neurosurgery and organizational neurosurgery in Kenya, in the continent of Africa, and worldwide, is with us today. So it's my honor to start by having our young neurosurgeon introduce herself and this session. Thanks so much.
Thank you, Dr. Dempsey, Professor Dempsey. So I'll start directly with my slide. The honor is mine today to host and moderate the session. It's a FIENS session on virtual visiting professor webinar. Like we all know, FIENS has dedicated itself to increasing the workforce and the workforce of neurosurgery in worldwide, particularly in low and middle income countries over some years now. I am a pure product of FIENS fellowships. So I am Nathalie Ghomsi. I'm a native Cameroonian medical doctor who is actually in the postgraduate year for neurosurgery residency in Côte d'Ivoire. So FIENS has helped me a lot since I'm not I had no governmental support. It was mainly my pocket and my family's pocket. So I had to go through extra hospital night shifts as general practitioner to pay my school fees and daily expenses. This reduces your concentration, availability, and opportunities to learn surgical skills, especially that neurosurgery is a capricious partner which demands a lot of time. So since then, 2001, I've been able to pay 2 years of my school fees and daily expenses. I've even been able to take a master's program in anatomy at the university. I've gotten involved in various researches. I got 3 scholarships. I also improved my neurosurgical skills, and I am actually pursuing to become a neuro-oncologist and skull-based surgeon. So my gratitude goes to these beautiful people, amongst which the chairman, Professor Robert Dempsey, followed by Professor Rousseau, who really mentored me. I will also say a big thanks to Dr. Laura Lipa, who really introduced me and gave me the opportunity to postulate for this fellowship, followed by Dr. Esene, who supported me and believed in me. So mentorship is really important in our field. As you see the elders, that's how you want to follow their steps. So in my right is Dr. Esene, which all of us we know, who is actually in Gara, working in Gara. Next to him is Dr. Bello Fugim, who mentored me, and might be when I'll be finishing, I'll be getting at their place to work with them in Gara. So today we are going to, we know that spinal spinal cord disease remains a huge scourge in our society, particularly in LMICs, which is dominated in children by infectious disease such as tuberculosis and degenerative disease followed by tumoral diseases. So for many years now, it's been, it's only the 4 previous decades that neurosurgeons started implicating themselves in spine surgery. It was mainly dominated by the orthopedic surgeons previously. So today we have Dr. Mubashir Mahmood Qureshi, who will be presenting us the history of spine surgery and its history on the African continent, particularly in neurosurgical perspectives. So how it started. Actually, Dr. Mubashir Mahmood Qureshi is a board-certified fellowship-trained neurosurgeon who is specialized in general surgery. He also does brain and spinal tumors, complex minimally invasive and revision spine surgeries, lateral access surgeries, and degenerative deformity and spinal fusion. He happens to be the chairman of Neurological Society of Kenya, the treasurer of the Kenyan Society for Epilepsy, immediate past president and honorary president of the Continental Association of African Neurosurgical Societies. He is also a founding member of COSEXA, a WFNS Neuroendoscopy co-chair, a member coordinating committee for the International Initiatives, WFNS member, nominating committee of the WFNS. He happens to be a board member of the Foundation of International Education in Neurosurgery, a founding board member and a vice president to Neurosurgical Education and Development Foundation based in Valencia. Professor Dr. Mubashir is also very dedicated to improving neurosurgical studies in our setting, as many of his articles not cited here are focused on neurosurgical education in Africa. So welcome, Dr. Mubashir Qureshi, and the honor is ours to have you here to present today.
Thank you very much, Dr. Ghomsi. Oh, that was quite an introduction. Thank you very much. It's humbling to have such close friends that are here joining us today, and to be able to have that short CV broadcast is kind of very humbling. I want to thank Bob for this initiative. Bob's been like the guru of global neurosurgery for decades. I don't know any continent that Bob has not gone to in order to promote the development, the education of both the academic and research components, as well as being hands-on the clinical tutor in many, many LMIC countries, including Kenya, including Tanzania, including Uganda, where he's gone single-handedly and been involved in surgical work and clipping aneurysms and doing all sorts of things. So Bob, you have so much energy and we all try to emulate you. It's also a pleasure to know that in here we have Abedi Kinasha, who really is on the board alongside myself of FIENS for many, many years. Abedi has been a leading light in the neurosurgical world in our part of the world. Welcome, Abedi. Brendan, it's always nice to see that you are here. A young Ehanga Idi Marcel, who is a WFNS Foundation fellow, is also here. Ignatius, what can we say? Ignatius is the powerhouse of young neurosurgeons on our continent and close. At the moment, he is the chairman of the World Federations of Young Neurosurgeons Committee, and he's also the secretary of CAANS at the moment. And what would I do if it weren't for Paul Young, who really has been the driving force in so many ways of East African neurosurgery, and was responsible for the training curriculum that we have now in COSEXA. And Paul will be remembered for carrying lumbar spine specimens in his suitcase to come and give tutorials here. So thank you very much for joining, Paul. And in a small, humbling way, I'd like to introduce as well, or recognize from Namibia, it's Amir Qureshi, who is the young neurosurgeon from Kenya who's done a double fellowship, but then realized that spine was hugely important, so went for a spine fellowship. And I have to say that he comes back and teaches me a few things as well. So with that, I'll start sharing my screen. And if I may, please confirm that you can see my slides.
Yes, we can see the slides.
So thank you very much again, FIENS, for this opportunity. And the aim of this is to essentially for the young neurosurgeons to know from a neurosurgical perspective. I know there is a similar history being provided by orthopedic surgeons from an orthopedic perspective, but this is going to focus on the neurosurgical perspective of spine surgery. And it essentially summarizes what we essentially found out through a very, very large review. And I have to thank Mehmet Zileli, who was the president of that, the World Spine Committee at the time, along with Salman Sharif, who then got all these individuals together. And you will see that Ignatius is there and Salman is there and so many others from across the world that has presented to us a very nice essay on the history of spine neurosurgery and spine societies, which has been quite illuminating. And that's formed the basis of what I'm going to present today. So the background of spine, neurospine, is that historically, as we all know, spine and spinal cord surgery have been an integral part of any neurosurgical training program. I mean, day one, you get into a neurosurgical training program, you begin to get involved in looking after spine. It was always a part of neurosurgery education and practically forms the significant part of any neurosurgeon's daily workload. However, with regards to the spine societies, we've got to give credit to our orthopedic colleagues, because they are the ones who decided and pioneered that we should get together into societies, and spine societies have been mostly pioneered by orthopedic spine surgeons. And it's only in the last 4 decades that neurosurgeons as well have started forming spine societies, so much so that the Kenyan Spine Society just formed last month. I think tried to form it about a decade ago, but now we have a spine society in Kenya, for example. So it's a recent phenomenon. The term of neurospine is gaining traction, and that's because it indicates the relationship of neurosurgery with spine surgery. And we, as neurosurgeons, widely prefer to use it because it kind of gives the message that the spine is basically there to safeguard neurological structures, and that neurospine also denotes that combination of science and spine, which we all wish to promote. So getting into the history of neurospine surgery, we all know that it's before the 19th century, and not just the 19th century globally, but even here in Africa, spine surgery was mostly conducted by general surgeons. Neurosurgery as a discipline was formed at the beginning of the 1900s, and the first successful laminectomy was performed by Smith in 1828 in the United States. The operation was a multi-level laminectomy for a paralyzed patient after spine trauma. Not only did the patient survive, but he regained partial function. Cervical tongs were then to come in. Hepburn, a British neurosurgeon, designed this cervical traction of skull tongs for cervical spine traction in the mid-1920s, beginning to treat wounded soldiers during the First World War. This was long before Crutchfield, whose design is shown on the right, his publication in 1933. In 1891, Hadra described wiring of spinous processes to treat cervical fractures. And then in 1910, Taylor described the hemilaminectomy technique. Ellsberg from Europe described the successful decompression of lumbar spine stenosis in 1911, and posterior lateral mass fusion was later added to Albion Hibbs technique in 1911 and remained the standard for over 50 years, first utilized for instability in tuberculosis patients. Cloward then came in and is credited with championing the posterior lumbar fusion. Tumor surgery then began to develop, and interestingly, Cushing, who's known for so many things, was the first one in 1905 to attempt the removal of an intramedullary spinal cord tumor. But even the great Cushing had to abort the procedure after the dorsal column myelotomy. Soon after, Charles Ellsberg took the cue, performed a two-stage procedure to remove an intramedullary tumor. First, a myelotomy, and left the dura open. A week later, went back in for a second stage, by which time the tumor had extruded from the cord and was easily removed. Metallic implants then began to come in. Harrington reported rods and hooks along with wires for compression and distraction to treat scoliosis in 1962. Larson in 76 described an aggressive lateral approach to the spine, calling it the lateral extracavitary approach. And here on the right, we see the hooks and rods being placed for a patient. Lumbar disc surgery is recorded as having first been come into the scene in 1929, when Dandy described two cases of what he called loose cartilage from the vertebral disc, which was causing cauda-equina syndrome. But the critical publication, and which we all kind of refer to regarding lumbar disc herniation, was that of Mixter and Barr in 1933. They had diagnosed preoperatively that this was due to a ruptured disc and reported a successful resection of this preoperatively diagnosed disc lesion. Then came the use of the operating microscope. Yasukil, a great leader in neurosurgery, and Caspar pioneered discectomies using the operating microscope. And you see one that I actually first used when I came back from training to Kenya. And interestingly, Paul will remember having carried in his luggage all the way from St. Louis, USA, a very similar, exactly, I think, the same microscope in his luggage, all the way from the US for teaching here. Williams described the procedure of lumbar microdiscectomy in 1978. Cervical spine surgery then began to be more in vogue. In 1958, Cloward pioneered the ventral approach to the cervical spine. With this technique, it was easy to remove the disc and fuse the level by placing a bone dowel taken from the iliac crest between the vertebral bodies. Then came the refining of metallic implants. Anterior cervical instrumentation was initiated by Bagby in a horse, interestingly, using a cage in 1988. Caspar popularized the anterior cervical plating system in 1989, and Brentingen and Steffi combined interbody fusion with pedicle screw lateral stabilization of the lumbar spine in 1993. Transforaminal procedures and approaches then got developed. Wills et al. Described the longitudinal separation of the sacrospinalis muscles from the multifidus and longissimus, as they called it in their paper. Cambin introduced the transphenomenal approach to disc herniation in 1973. However, limitations of this technique frustrated surgeons and eventually led to the development of larger tubular surgery. And Foley et al. First reported lumbar discectomy using an endoscopically visualized tube in 1997. A minimally invasive approach to the spine was described by Feisler and Macmillan and subsequently published by Mayer in 1997. The tubular system became popular for performing discectomies and laminectomies. Fessler and Co. developed multiple subsequent operations between 1990 and 2000, including minimally invasive cervical foraminotomies, decompression of stenosis, T-lifts, thoracic discectomies, resection of intradural tumors, and correction of scoliosis. Then came the percutaneous spine approaches. Now we're coming down towards the 2000s. The first widely accepted percutaneous pedicle screw system, the sextant, was described by Foley in 2001. This utilized smaller multiple incisions to carry out pedicle screw fixations using this sextant system. Fessler and Co. first described minimally invasive interbody fusion and percutaneous pedicle screw placements in 2002. And the Foley's group adapted transforaminal interbody graft and cage placement using tubes in 2005. Posterior cervical approaches. Scoville et al. First described the posterior cervical discectomy in 1976. Adamson adapted a similar technique with a tube foraminotomy in 2001. In the 1990s, most neurosurgeons were performing cervical spine fixations. However, orthopedic spine surgeons developed the pedicle screw fixation systems for thoracic and lumbar spine, and that's where the credit goes for orthopedic surgeons who then brought in pedicle screw fixation. And it was some time before the neurosurgeons started, it took time before neurosurgeons began to use pedicle screws. The approaches to C1 and 2 in 1910, it was silk sutures that were used to fixate atlantoaxial instability. And didn't last very long, as one can imagine. Gailey first developed C1-2 wiring, followed by Brooks and Jenkins, and then Dickman et al. Described it in the 1980s. Advancing atlantoaxial surgery, Atul Goel was the first to describe plate fixation of lateral mass, C1-2, in 1994. This technique allowed the reduction of C1 subluxation on C2. It is deemed safer than Magel's transarticular screw fixation because it reduces the chance of a vertebral artery injury. Goel then improved this design, classified the whole range of basilar invagination in craniovertebral anomalies, and achieved the posterior reduction by placing a spacer between the atlantoaxial joint. This was a paradigm shift because it made transoral odontoid resection surgery unnecessary. Arthroplasty was then introduced by Atkinson, first initiated this in 1950s when he injected self-hardening silicone rubber into cadaveric discs, demonstrating restoration of disc properties. In 1966, Fernstrom implanted the first artificial disc device. Spinal arthroplasty evolved slowly, and by the end of 1990s, it became a realistic treatment. The FDA in the US approved the first lumbar arthroplasty device in 2004. Lumbar arthroplasty reduced interest for lumbar. There was a reduced disc reduced interest for its use in lumbar disc, but cervical arthroplasty has gained more interest than lumbar and is more widely used. Then comes the era of navigation and robotics. In 1985, the programmable universal machine for assembly, the Puma 560 Unimation Danbury, Connecticut, USA, became the first ever surgical robot used to perform a neurosurgical brain biopsy with better reported precision than techniques of its time. And now, David Roberts is credited with merging modern stereotaxy with CT in 1986, setting the stage for navigational concepts behind robotic spine surgery. In 2004, the Spine Assist from Israel was the first robot approved by FDA for use in spine surgery and remains one of the most widely used. The Spine Assist is a shared control robot that offers navigation that's apparently superior to traditional intraoperative navigation. Although cost is a limiting factor, it's not going to be far before the future generations, and all the young neurosurgeons in this forum will be using robots because they have the potential to improve spine surgery for both patients and providers alike. So I'll now shift gears and give us the history of spine surgery in Africa. The paucity of information from across Africa has to be acknowledged at this point, and that's why I take this as an opportunity and perhaps a challenge to our young neurosurgeons to perhaps initiate a wider survey of what the history of spine surgery is in Africa. And I'm sure that Ignatius, his ears are perking up, and Ignatius will be able to drive this through the Continental Association so that we can actually do the African continent a justice by indicating that there was spine surgery and how it has come about in the continent of Africa. So the authors led by Salman Sharif and Mehmet Zileli, through their surveyed spinal neurosurgeons in all the 5 continents, different countries, and wrote to all of them to learn the evolution of spine neurosurgery and societies in their countries. We managed to collect, when we say we, it's the authors that are on that page, and I know that there are several who you will recognize. We collected the past and current status of spine surgery, and responses were received from all continents, and only included 30 countries, but I'm sure there's lots more to be done in this area. The neurosurgical societies globally that was surveyed, in the Americas, it was the USA, Mexico, Colombia, and Brazil that provided responses. In Europe, Germany, Netherlands, Belgium, UK, Ireland, Switzerland, Italy, Portugal, Russia, Serbia, Bulgaria, and Turkey. In Asia, it was the Chinese, the Japanese, the Taiwanese, the Indonesians, the Filipinos, the Indians, the Pakistanis, the Bangladeshis, the Nepalese, and the Iranians who provided responses. From Africa, we received responses from Egypt, from North Africa, Nigeria, from West Africa, Kenya, from East Africa, and responses were regrettably not received at that time from Central, Southern, and Southern Africa and South Africa. And there's a lot that goes on in these areas. This, therefore, as I mentioned, provides an opportunity for us for a further survey of all African countries, as several have a long history of spine surgery. I know that Ethiopia, South Africa, DRC, Côte d'Ivoire, Cameroon, Zambia, Zimbabwe, Uganda, Tanzania, all have had spine surgery and can contribute to such a publication that if we were to go about finding it. So let's look at Egypt. The first trials of laminectomy were performed at the Qasr Al Ain General Surgery Department by late Professor Zekri. The spine activity by neurosurgeons actually started in 1955 in Cairo University by Professor Soror. The Egyptian Society, of which our very, very active colleague, Professor Nasser Al-Gandour, who has become a champion of international webinar at the moment, and is the current president of the Egyptian Society. This society is one of the longest ones on the continent. It was founded in 1967. Professor Boktor was appointed as president of this society. The spine subspecialty of the Egyptian Society was created in 2006. The Egyptian Neurospine Group represented a natural development and maturation within the Egyptian Society. Spine practice in Egypt is mainly conducted by neurosurgeons. The orthopedic spine surgeons mainly conduct deformity correction surgeries, and instrumented fusion surgery started in 1970s in Egypt with ordinary plates and screws. The Egyptian Spine Society, launched in 2011 by a group of orthopedic and neurosurgeons, was an offshoot of the Egyptian Society, and they have, I believe, amongst the largest number of orthopedic and neurospine surgeons. And Egypt is really a hub of neurosurgery, spine surgery on the continent. They hold annual meetings, although there was a period because of the problems they faced politically, and this became briefly interrupted, but it's now been revived again. The history in West and Central Africa. In West and Central Africa, surgical spinal pathology management is almost exclusively done by neurosurgeons, and they are involved in the decompression of the spinal cord and stabilization of the spine. Gradually, in each neurosurgical ward, spine subspecialties are evolving. There are no societies in this region dedicated exclusively to spine surgery. Traumatic spine injury is a major source of morbidity and mortality, as one can expect, given the LMIC situation. The frequency of compressive myelopathies and their etiologies has not been evaluated extensively. And again, this is an opportunity for our younger colleagues in this group to address this particular challenge. Epidemiological studies are not very common in this region. The history in Nigeria. Spinal neurosurgery has been practiced in the University College in Ibadan and Lagos University Teaching Hospital since 1966. The Nigerian Society of Neurological Sciences, representing neurosurgeons, was established around the same time that the Kenyan Neurological Society, which I wear the badge of, was established in 1966 as well. Spine cases treated by neurosurgeons include congenital malformations, tuberculosis, degenerative spine disease, and spine tumors, with few trauma cases. The Nigerian Academy of Neurological Surgeons, NANS, was formed in 2006. Professor Arik Babu was the first president and held their first conference in 2008, followed by a cadaveric course in Abuja in 2009. This Nigerian Spine Society, consisting of both neurosurgeons and orthopedic surgeons, was founded in Lagos in 2018 by Dr. Kabir Abubakar. The Nigerian AO Spine, which is a separate society supported by the AO Foundation, was registered in 2019. Dr. Ojo chaired the first scientific conference alongside a cadaveric workshop in Lagos in 2019. There are currently 60 spine neurosurgeons who have membership to both NANS and Nigerian Spine Society. Diagnostic facilities have steadily been developed in that country. MRI is now coming in. CT scan machines are now available in most teaching hospitals. C-arm fluoroscopy machines are available in over 30 hospitals offering spine surgery. And spinal implants has now coming into routine use in that country. Minimally invasive spine surgeries are also offered in a few centers. Spine neurosurgeons and orthopedic spine surgeons manage a large variety of cases, deformities included, and degenerative spine diseases. So I'll focus a little more of the country that I know most, and I know that Bob, as well as Paul and Abedi, have had opportunities to come and visit and work and teach in Kenya. So we'll focus a little more in the history of neurospine surgery in Kenya. Neurosurgery and neurospine cannot be mentioned without mention of the first neurosurgeon who was a force in himself, Professor Renato Roberti, who came from Napoli in 1965 on a hunting trip, and really was amazed that there was just not a single neurosurgeon in this beautiful country. He then decided to then come back, and here he is. He was a very, very vibrant and active member of the neurosurgical community of African neurosurgeons across the continent. And he essentially was responsible in Nairobi, in the town that I am based, of launching both the Neurological Society of Kenya in 1969 and of the Pan-African Association of Neurological Sciences, PANS, along with his friend Adilola Adiloye, may God bless his soul. Both of them are now departed from Nigeria. They really were the founding members and pioneers of the societies in Kenya and the continent. The role of Professor Renato Roberti was huge. He started the formal neurosurgery in Kenya and was the first chairman, and I take pride in wearing this badge as I chair the Neurological Society, which he started in 1967. He pioneered the Neurological Society, as I said, the Pan-African Society, and then the African Federation of Neurosurgical Society. All these societies then gradually led to our Continental Association, which was launched in 2012. Neurosurgery is mainly conducted at that time at the Kenyatta National Hospital, where I know that Bob and Paul Young have both helped in teaching and operating. At the Aga Khan Hospital again, and the operating rooms where Paul and Bob have worked with us, and at the Nairobi Hospital. In the mid to late 1960s, David Stewart, who was the orthopedic surgeon, and Renato Roberti developed spine surgery for TB and lumbar laminectomy for disc prolapse and spine stenosis. This was based mainly at what was referred to as the European Nairobi Hospital. The European hospital was named so because it was meant to cater only for the colonial European settlers at that time, with the others being treated at what was referred to as the native hospital, later to become the King George V Hospital, which then changed its name at independence in 1963 to the Kenyatta National Hospital. Professor Jawahir Dar, a neurosurgeon from New Delhi, joined the university in 1973 and is credited with launching a separate unit for neurosurgery, along with the first neurosurgeon, Professor Gershom Sande, and both taking neurospine surgery to other hospitals in the city, mainly the Aga Khan Hospital, which was specifically developed in response to the whites-only European hospital as a multi-ethnic hospital. The European hospital was launched in 1954 to serve the colonial population of Europeans, and its name changed to Nairobi Hospital in 1963. Here it is during the launch of one of the hospitals. The Aga Khan Hospital, here the young Aga Khan is seen working to launch the multiracial hospital in September 1958, which is currently the hospital where is the university hospital, where spine surgery is now regularly conducted. Microscopic surgery was introduced in spine surgery in Kenya. Yours truly returned from training in Southampton and was involved in performing the first lumbar microsurgical discectomy in June 1992 at the Kenyatta National Hospital in Nairobi. Yours truly also pioneered the use of hard cell rectangle and sublaminar wiring technique that he had learned in Southampton, England, used to stabilize cervical, thoracic, and lumbosacral region. Here is an example of the kind of fractures that would be used to stabilize with the hard cell rectangle. And yours truly was then taught by an orthopedic surgeon how to carry out pedicle screw fixations in 1996. So both are now available. We no longer use the hard cell rectangle in the private hospitals, but in mission sites where patients may not have access to the pedicle screws or might be prohibitively expensive, except in Zanzibar now, because that has had a major change with lots of individuals bringing in humanitarian and neurosurgery to that hospital in Zanzibar, and pedicle screw fixation is now done regularly in the mission, a humanitarian hospital in Zanzibar. But in other sites, we still do use the hard cell rectangle if the pedicle screws are not available. Younger generation of spinal neurosurgeons have come in from orthopedics. We have Dr. Akil Fazal, who carries out endoscopic spine surgery, and Dr. Kasmani from the neurosurgical side has learned the technique. Current approaches to the cervical spine instrumentation are now being carried out by Dr. Mubashir Qureshi, who's trained in South Africa under Robert Dunn, and has now been able to introduce the cervical spine lateral mass screws into neurosurgical work in Kenya. The spinal surgery now carried out in most of our hospitals uses intraoperative monitoring because it enhances the safety and improves outcomes. And this is one of the hospitals that in here using both the O-arm neuromonitoring, neuronavigation in actually the Nairobi hospital. This picture is taken from with Dr. Mubashir Qureshi and yours truly operating on in that hospital. Spinal cord stimulation has been developed as a service at the Aga Khan Hospital by one of our pain specialists, along with myself and others as a team, and being carrying out spinal cord stimulation for neuropathic pain. And this is a patient amongst the first that was done in that project. The spine workshop, spinal workshops are being carried out, and at the recently concluded CAANS Congress, there was an opportunity of international faculty from across the globe coming and conducting courses at the pre-conference course. It's both spine and brain at the CAANS Congress in November last year. And here is the Spine Society, which carried out a spinal surgery course at the CAANS Congress as well. So with that will be a plea to all of us in the audience to use this opportunity to stir up some publications. We've had the privilege of having both Ngobile from South Africa and myself from the continent join the Global Neurosurgery Editorial Committee. And really, Gail is the driving force. Gail Rousseau is the driving force along with Laura Lipa. We really would welcome or encourage our young neurosurgeons in this group to get into publications and perhaps send those publications, send those papers for consideration in neurosurgery, which has got this new Global Neurosurgery Editorial Committee and a section for global neurosurgery. So with that, I will thank you very much for the opportunity, Bob. And I hope that we've stimulated some interest in spine surgery on the African continent, and those who are from outside the continent in this webinar will also be enthused to get on and do more in spine surgery and contribute to publications. Thank you once again.
Thank you so much for this fantastic presentation. Very insightful, Doctor. All the questions, please, for all the panelists and the attendees, please, you could jot down your question in the QA session so that we could transmit to Dr. Qureshi. I am very impressed by what is done in Kenya. I think here in Côte d'Ivoire, we tried once or twice to do a minimally invasive surgery, but I don't think we have all the equipment everywhere. It's not as frequent. It's mainly in private hospitals, which are quite costly for every user. So it's really rare. This would be interesting for us to come and learn at Aga Khan how to carry out these techniques. So I will go ahead directly. Okay, there's no question. So I'll ask my question. I'll ask directly a question. So set up the flame. For only 40 decades, neurosurgeons started implicating themselves in spine surgery. So what was the turnover? Why did they decide at this point to go into spine surgery and not leave it to the orthopedist, doctor?
I think the answer to that comes from our training. As you know, orthopedic surgeons are basically trained broadly in all the areas of bone and joint, and if they do have an interest in spine, it is usually a very short stint during their training that they go into spine. And if they do want to then specialize in spine, they have to undergo a special fellowship in spine. I think the situation when certainly some of us trained was that you went into operating both the brain as well as the spine right from day one. I know the situation has now changed because there's a lot of material to be sort of learned, and we're going down the route of what the orthopedic surgeons have been doing, where during training, the neurosurgeons in their training only spend a shorter time in spine surgery. But traditionally, it's been spine and brain right from day one. So the only thing that we perhaps did not do as effectively, because we considered that spine and brain surgery were part of our forte, didn't think very much towards starting spine societies. The orthopedic surgeons, on the other hand, because they finish their bone and joint kind of training and then go into specialized fellowships in spine, when they come out, they feel the need to associate themselves with others, and therefore they were the first to start spine societies. That's my understanding of why spine societies were initially formed by orthopedic surgeons and not neurosurgeons. But I think it's now going to become more in vogue for people who specialize in spine, dedicate themselves to spine, to form neurospine societies as well. So I think the trend is changing.
Okay, thank you, sir. So we have a question from Dr. Isene Inashes. I think he's quite famous here from Cameroon. Yes, doctor, you can go ahead. Dr. Isene?
Have you given him? Yeah. Is he able to speak?
Yeah, thank you so much, Professor Qureshi. Thank you, Professor Ghomsi, and thank you, Nathalie, for this session. I just wanted to comment on what Professor Qureshi said about the spine surgery in Africa. It's true. When you don't know your history, you're bound to repeat it. So, and most of the data about spine surgery in Africa is actually published in journals which are not indexed. So sometimes it's difficult to find out the information. So I think we, as you propose, we are going to work on it so that we have some appropriate data. And with respect to the situation of orthopedics, I remember during my training, when we actually and there was a spine fracture related to maybe a fracture of the femur, the orthopedists had to come in because they told us if you want to take the spine fracture, then we have to take everything. So that was the reason why most of the spine fractures were managed by the orthopedics. Thank you so much for the webinar. It was really inspiring. I think we've learned about the history of spine surgery. We know where the gaps are, and we're going to try to mitigate these gaps. Thank you so much, Professor Ghomsi. It was good to see you again. Happy New Year.
Thank you. So the next question comes from Professor Ghomsi. Professor Ghomsi, you have the floor.
Yes, Moody, I was recently in Vietnam with Brandon and so impressed with first steps on intraoperative monitoring, which got me thinking, what pearls would you have for the audience who is starting out about how to adapt intraoperative monitoring and navigation, say, cerebral navigation to spine? What should be their first baby steps to go, because they're not going to start with a robot, to go from loops to the next step in spinal neurosurgery? How do we get those regional hospitals up to par?
I think the way we've kind of approached it is to encourage perhaps initially one or two hospitals to become the hub so that people become used to this and are more attuned to referring patients for such surgery. Ultimately, over time, more hospitals will get into it, but certainly having an individual neurophysiologist or someone interested in neurophysiological monitoring, they usually come from a background of technologists who are in the departments of neurophysiology, and they then can go for a fellowship or a training period with some experts. And we've got people both in Africa and Italy, interestingly, who have offered the opportunities to these people. So once you get the neurophysiologist trained, and then you select out the one or two or three main hospitals where neuromonitoring will be developed, then you'll find that the interest from other specialists comes in. They come in and they watch you and then take that message back. So we've had that experience with the 2 or 3 hospitals in the country where we tend to use neuromonitoring regularly. And don't just wait for it to be for the thoracic spine tumor that you're going to do neuromonitoring for. Go ahead and use it even for spina bifida. I know that Jesus Lafuente, when he was doing a mission in Mombasa, where there are lots of spina bifida, brought in a neurophysiologist along with him. And introduce neurophysiology monitoring in spina bifida, which is a good thing to do, because you sometimes while operating feel that you may end up sacrificing some root outlets, and if you can pick those out with neurophysiological monitoring, learn the technique. There's lots of spina bifidas, and you could do that. Use it for straightforward, not for microdiscectomies, but certainly for multi-level fusions. It's something that one should use. As the neurophysiologist then gets used to this, then the more advanced type of neurophysiological monitoring for intramedullary tumors, etc., then comes in. With regards to the neuronavigation, it's an expensive tool. So you've got to fight for that to be introduced, because the management is always going to look at, is it going to make us more money? Well, that's true. But then if you can then sell the case that if you have neuro monitoring and neuro navigation, you're going to influence a lot of referrals from other hospitals, particularly from those patients that would ordinarily, from our setting, wish to go abroad, and that traditionally were ending up going to India or to Dubai for surgery. But now the hospital is able to market the fact that it's able to carry out these surgeries safely, because we have neuromonitoring, you have neuronavigation, and then the hospital will see the sense in investing in it. And we've managed to at least convince the two main hospitals in the city to invest in neuronavigation. One of them then was encouraged to invest in an O-arm. So it's a question of making a business case, but you've got to be a bit more persistent and a bit of a nuisance to the administration and the CEOs of the hospital to try and convince them. You can't just let them dictate what they will purchase just on the basis of financial consideration. You've got to show that these improved outcomes, improved surgeries will result over time with more referrals, and then the business case will be met. So yeah, the way to go about it.
Dr. Qureshi is too kind to mention, so I will for him, that his leadership as a senior surgeon going hands-on, working with that regional hospital with the first use of equipment, be it endoscopic or otherwise, has really allowed the spread of higher quality neurosurgery throughout the region. That's really the collaboration we're talking about. Thank you.
Thank you so much, Dr. Ghomsi. So the last question will be from Dr. Augusto Jacinto. However, we have many other questions, but we are sorry, we are caught up by time. So these, the rest of the questions could be answered offline. So the last question will be by Dr. Augusto.
Albert, okay. Good evening. I am Augusto. I am Augusto Jacinto Alberto. I am resident in final in Mozambique. I'm doing neurosurgery. I ask if it's possible to have some opportunity to do some spine fellowship in spine fellowship.
Just repeat that question again, please.
Okay, I'm used to talk in Portuguese, but I try to improve my English now.
Oh,
I thought that I will do my last my final exam next month, but now I'm looking to do some spine neurosurgery in future. It's why I ask if it's possible to have this opportunity.
Absolutely. You know, Ignatius is on and he's trained in Egypt, interestingly. He's also the secretary of CAANS at the moment. But the Continental Association has actually signed a collaboration, a memorandum of understanding with Professor Nasser Al-Gandour and the Egyptian Society to enable fellows from the African continent to train there. So at the moment, it is through the College of Surgeons of East Central Southern Africa, COSECSA. We signed the memorandum. I know that Mozambique is a part of COSECSA, and you, through your leadership, can approach myself, and I would be happy to link you up with Professor Nasser Al-Gandour, because that's one country that has really lifted the bar. And as Professor Paul Young has said in his comment, the emphasis on any development anywhere is going to be education, and the opportunities for education through fellowships has come about. The Continental Association did that. COSECSA has done that with the Egyptian Society. So if you write through your head of department to myself, or even to the secretary of CAANS, I'm sure we will be able to link you up with Professor Nasser Al-Gandour and organize a fellowship for you. The other fellowship that is of very high quality and is available is in South Africa, but the high quality fellowship is actually available through the orthopedic department, and they tend to select out their trainees for fellowships well in advance. So because Ian Flock from Tygerberg in South Africa is also a member of the Spine Society, WFNS Spine Society, I think it's a question of getting these collaborations, and really that emphasis has to be there. I know that there are always going to be opportunities for short-term courses. The Zanzibar NED Foundation runs courses as well. So if you keep a watch on that through the website, you will find that you will be able to make contact. I know that we were supposed to have one such course in November with Paul Young and Jose Piquer, but it got delayed because of some other issues, but there will certainly be courses this year as well. So there are opportunities, is what I'm trying to say.
Okay, thank you.
So thank you, everyone. Like I said, this session will be recorded on the YouTube channel, FIENS YouTube channel, so everyone can find the video of the whole session. Thank you once more, Dr. Qureshi, for this beautiful and insightful presentation. Thank you, Dr. Dempsey, who is the chairman of the FIENS, for giving us the opportunity to, giving us low and middle income countries the opportunity to have quality training, no matter quality training, so set back or give back to our communities. So, and thank you everyone, every attendee for taking part in this wonderful session once again. So we'll see you at the next session in March, which will be hosted by Dr. Hassan, who is from Tanzania. Thank you, everyone.
There's just a small question from Landry Conan from Abidjan, asking about the supply of spine implants. I mean, spine implants can be very expensive, but you need to know that there are some very expensive ones and some fairly reasonably priced ones that are from are manufactured in other countries. There's the Chinese implants, which are not too expensive, not as expensive as the ones from Medtronic, for example, or Globus, but there are Indian ones as well. And we have contacts in Kenya who bring in the various types of implants. And depending on the patient's ability to pay, we offer them a range. And some will say, okay, I would have preferred to have the Medtronic one, but I can afford the one from China or the one from India. Is it just as good? And when you actually look at it, they're actually pretty good. It's just that their manufacturing costs are lower because the technicians in the engineering departments in India don't charge as much as they do in Germany, for example, for their work. So you end up with a equally good product. I'm not promoting any. I'm just saying that you have the option to get other less expensive implants. So we've used that approach here. Thank you. Right. Thank you very much.
Many
Bob,
thanks.
Also,
many thanks. This is outstanding and beautifully moderated. Thank you so much. Very proud of you. We look forward to seeing you again in March, and we'll send out information on that presentation.